The following podcast is part of a certified educational activity titled Steering Away from Steroids in Myasthenia Gravis Management, the role of FcRn inhibitors in the current treatment paradigm. Access the entire activity and complete the post-test at peerview.com/JDS860. Downloadable slides and practice aids are also available.
Hello, and welcome to this PeerView Live program, Steering Away from Steroids in Myasthenia Gravis Management, the role of FcRn inhibitors in the current treatment paradigm. The goals for today's session are as follows. First, to help you develop monitoring plans for steroid-related adverse events, to enhance your understanding of evidence for FcRn inhibitors in achieving steroid-sparing generalized myasthenia gravis treatment, and to equip you with the skills you'll need to incorporate FcRn inhibitors into treatment plans for appropriately selected patients who have GMG. I'm going to begin talking about safety first, strategies for monitoring corticosteroid-related adverse events in GMG. I'm a professor of neurology, medicine, and allied health in the Department of Neurology at the University of North Carolina, Chapel Hill. Globally, MG has about an annual incidence of 8 to 10 cases per 1 million persons, with a prevalence somewhere between 150 and 250 cases per million. It's a rare disease. Its core manifestations, the sine qua non, if you will, is fatigable muscle weakness made worse by activity or exertion, improved with rest, only to recur with a resumption of activity. Symptom fluctuation is a hallmark, and the demonstration of this in terms of the eyelid or the muscles of eye movement is proof positive of myasthenia gravis, as no other disease will do it. The most common presenting symptom is ocular, either with double vision, ptosis, which either of these may be symmetrical or asymmetrical, and occur in about 80% of patients who have the disease, though they generalize to more diffuse weakness within 2 years of disease onset. Some individuals may present with bulbar symptomatology, resulting in dysarthria, dysphagia, or facial weakness, an atypical smile where they seem to be grimacing at you, when indeed they're smiling, and it's because the corners of the mouth cannot retract upwards, but rather move horizontally, but the middle portion of the lip elevates, and so they have what we call this typical myasthenic snarl. Axial weakness can also be present, more so with neck flexion than with extension. And individuals may have limb muscle weakness, and typically symmetrical, but may be asymmetrical at times, more proximal than distal. And these distal muscle weakness may involve the fingers, the wrist, some flexion, extension, and occasionally foot drop. 15 to 20% of patients with acetylcholine receptor antibody myasthenia, and we'll come back to the antibody status in a bit, may develop respiratory muscle weakness that will require mechanical ventilation and intubation. And if that occurs, we term this crisis. The goals of treatment have evolved with the advent of new therapeutics, the fact that we have choice now. In the MGFA task force, in their most recent writing in 2016 and modified a little bit in 2020, says that we want our patients to be asymptomatic, to achieve what we call minimal manifestations, in which there are no symptoms of muscle weakness, there's no functional limitation, though they may have subtle weakness on very detailed examination, such as weakness of eye closure, or perhaps you can push their deltoids a teeny bit, but to the individual, there is no impairment whatsoever. We also want them to have no or minimal treatment-related adverse events, CTCAE grade 1 or less. And then remission is defined as no signs or symptoms of myasthenia, though we do allow weakness of eye closure in these individuals, but no other weakness anywhere else on detailed neuromuscular examination. There are various subtypes of myasthenia and numerous ways to classify these individuals, and one is based on antibody status. The majority of patients, about 85% or so, will have antibodies to some determinant on the acetylcholine receptor. These antibodies are typically IgG1, IgG3. These individuals typically will present with thymic hyperplasia in those who are young, and occasionally in some 10, 12, 15% with a thymoma. Another subtype are those who have antibodies to muscle-specific kinase, MuSK as we call it. These are of the IgG4 subclass, and they're found in about 7 to 10% of patients who have myasthenia, and up to about 40% of those individuals who do not have antibodies to the acetylcholine receptor or who are seronegative. And then there's some other subtypes. We have a very minority who have antibodies to LRP4. And then there are those who are seronegative. And I would caution you in reading the literature regarding seronegative myasthenia, as this definition has evolved. When I initiated my training in the mid-70s, everybody was seronegative because we didn't have an antibody assay. And then we developed the antibody assay to acetylcholine receptor, and so anyone who didn't have antibodies to that were seronegative. And when MuSK came around, we now had those who were seronegative didn't have antibodies to those two. With LRP4, it's now 3, and who knows where this will stop. And so it's an evolving process. We classify myasthenia gravis based on the MGFA, Myasthenia Gravis Foundation schema, originally developed at the University of Virginia by Dr. T.R. Johns. And we're not going to go into all the nitty-gritty here. We'll let you look at the slide, read it yourself. But broadly, we have 5 classes of disease, 6 when we include those who have no disease. We call that class 0. They're in remission. But 1 are those who only have weakness of ocular function. 2 is mild, 3 is moderate, 4 is severe disease, then 5 is what we call myasthenic crisis, requiring mechanical ventilation with or without the use of a feeding tube. We then subset these as to whether they're predominantly limb involvement with ocular involvement or predominantly bulbar involvement with lesser degrees of ocular and limb involvement. And we use this in terms of our clinical monitoring as well as our clinical trials monitoring. Now, this is the headline of an editorial written by Carolina Barnett back in 2021 in Toronto. Patients with myasthenia are getting better, but are they really doing well? It was a survey commenting on the results of a Swedish survey among patients with MG, over 1,000 of them. And 47% of these individuals scored more than 3 points on the Myasthenia Gravis Activities of Daily Living Assessment. This is a patient-reported outcome measure, if you will. And scores of 3 and higher often reflect dissatisfaction with their level of disease control. And so, yes, motorically, muscle strength-wise, they were clearly better, but their quality of life was not. And this was a call to arms, an awakening, if you will, that we need to do better. We talk about burden of myasthenia, burden of disease resulting from weakness, and burden of treatment, typically related to the adverse events of the therapeutic we're using or the logistics necessary to treat our patients. But the burdens are widespread, and this is sort of a composite of areas where individuals have significant difficulty. Clearly, the disease impacts physical mobility and strength and those kinds of activities. But in addition, it takes an emotional toll on the individual. It has societal impacts. The individual with double vision, difficulty navigating in crowds on a street, may stumble, may be perceived as being intoxicated, for instance. They've lost depth perception because of their double vision and have difficulties. Um, the activities of daily living are clearly impaired. They have to plan, they have to adapt. Because the disease fluctuates, one can never set a plan in place and stick to it continuously. So there's these constant modifications that intrude into the quality of life. Clearly impacts their hobbies and their sports, and there's absolutely no question of the toll it takes on their career, their ability to work. And there's good data in other countries. For instance, more than 50% of patients with MG in Thailand are unemployed. In Japan, it's approaching 30%, a little more than 30%, but an additional 10 to 15% have reductions in income, such they have concerns about caring for their family. In Australia, it's somewhere around in the low 40%. So huge societal impacts as a result of this disease. Patients will tell us that even when treated, their disease is burdensome. And there are several interviews that have been done looking at longitudinal courses of patients with MG, and this is just one of them. For instance, 42% of patients in remission in prior to baseline, and then only 45% after 10 years. Numbers of patients with depression and anxiety didn't change over this time. They still had difficulties coping and adapting with their disease, in part because of the fluctuating nature, in part because they were not fully controlled and totally asymptomatic, in part because of the impact on their societal functions in terms of job, caring for family, etc. And so the patient's perception of poor quality of life persists even if they're well treated from a physician's perspective, and we must remain attuned to that. And when they tell us, yes, I'm doing okay, one needs to drill down on what okay means. I often am concerned because patients develop what I call the second normal. Their disease has been insidious, it's been a prolonged duration, and they adapt and accept that which it is as being normal. And you don't find out about this till you treat them sometimes. And you treat the individual, and he comes back to you in clinic and says, I didn't realize I was this weak. I thought it was just my age because I couldn't drive on the golf course and so far. And now I'm going 50, 100 yards farther. Or I was a 5-putt golfer. And now I'm a 2-putt golfer because vision was improved, because muscle force was improved. But they had accepted that they were just normal and becoming elderly. So there are multiple sources of patient dissatisfaction with our therapeutics. One of the big ones is the delayed onset of effect of our therapeutics, which may take 4 to 6 months. And one therapeutic we use, azathioprine, may take 10 to 12 months to start working, to say nothing of maximum effect. Prednisone works quickly over the course of weeks, but many of our nonsteroidal ISTs are very delayed in onset, with maximum improvement coming somewhere between 12, 18, 36 months down the road. And then based on various surveys, 8 to 41% talk about the lack of efficacy. And we must be careful again that the older individual, the sedentary individual, may be accepting weakness as such as being normal when in fact they can do better. And then we have about a third who are dissatisfied with the logistics, having to go to a facility for plasma exchange or intravenous immunoglobulin because they can't get it in the home. And in fact, in Japan, if you're given IVIG, you have to be hospitalized. Here in the US, many of us use infusion centers or home administration. More than a third were distasteful of the adverse events of our common therapeutics. And if you're on a corticosteroid, that number jumps to over 80%. And while prednisone is an excellent therapeutic, and it's one of the most hated drugs we use because of the adverse event profiles of that drug. And we've already talked about the logistical components of this. As I already alluded to, glucocorticoids are the best and worst for the patients with MG. And it's been our mainstay since the mid 70s when I started training. My mentor was involved in the initial use of corticosteroids for treating myasthenia in a population of patients who had associated inflammatory myopathies, myositis, and both diseases got better. And we've continued to use them. And there are multiple paradigms that we can use, going high to low, which is how I was trained, or low to high, which others use. But they've been our mainstay, but with them come problems. Um, while effective, they may be ineffective in some. And in Japan, about 35% of patients did not meet their treatment goals following 3 years of the use of oral prednisolone, even in combination with calcineurin inhibitors. And we've alluded to, and you know, many of the adverse events of steroids, and we'll delve into that in a little bit. Here is a bar chart of the frequency of complaints in terms of steroid adverse events in 39 patients. And one sees that the too high in terms of weight gain, glucose intolerance lead the list. But look at the plethora of other side effects these individuals have. And I think we need to be um, tuned into using how we use them in order to minimize these adverse events. Um, Regardless of dose, corticosteroids can lead to adverse events. And these are retrospective, of course. We don't have good prospective studies on this. But even with uh, low doses of corticosteroids, we are seeing adverse events. Patients treated with oral steroids more than a year experience from a range of 2 to 6 of the adverse events that I showed you in that previous bar chart. And then we need to think about what are the costs associated with glucocorticoid toxicity. Many of the studies that are done to look at what are the cost of therapeutics through groups like ICER, et cetera, never really take into account the associated costs of treating adverse events. And corticosteroid toxicity in many of our autoimmune disorders can be as much as $30,000 to deal with it. And sometimes, if it's significant with development diabetes, osteoporosis, limb fracture, that cost can even be higher over the lifetime of the patient. There are a number of ways to monitor for steroid adverse events. I think we, as clinicians, do a modest job, but I think we can do better. We often accept the weight gain in many of these patients, which to a young individual, particularly a woman, is an anathema to us. And I've been yelled and screamed at many times by some of my younger patients because of what it does to body image and their ability to go to the prom, etc. In our younger children, we worry about stunting growth. There's clear effects on BMI and blood pressure. And so there are multiple laboratory studies that we should be monitoring in terms of glucose monitoring, in terms of lipids, in terms of mean body index and BMDs. We need to be looking at bone density in terms of bone health. In our older population, we clearly demineralize bone fairly rapidly. And I've been instructed by, particularly my rheumatologic and endocrinologic colleagues, that much of this, particularly in the older individual, occurs early, within the first 3 months, not 12, 15, 24 months down the road, but we're already seeing effects early. And so we need to set up a monitoring plan and we need to stick to it and do it annually or more frequently if necessary based on what we're dealing with. And so DEXA scans, spine films, looking for fractures if there's pain, looking at A1Cs, etc. Getting involved with our endocrinologists, particularly orthopedics or rheumatology, if appropriate, based on what we're dealing with. Dyslipidemia impacts cardiovascular risks, and clearly with steroids, we see this risk increase. And so lipids should be assessed initially, prior to the initiation, and then periodically thereafter, based on how the patient is responding, the other clues that we get in terms of all of their associated issues. Cataracts are often seen 10% in some papers. And so we need to be sure that they don't have cataracts to start. And then we typically have them monitored on a yearly basis if on corticosteroids. And then, depending upon what is seen, that may be a tip off for early diabetes if we're not picking it up, having retinal changes, etc. Um, the diabetic issue is of real concern, particularly in the US, where more than 10, 15, in some cases that I've read, up to 20% of our US population has prediabetes, diabetes, in part because of dietary habits, starting as youngsters. And so they're overweight, they have increased BMI, and then the use of corticosteroids contributes to the development of worsening glucose control. And so we need to take this into account and keep that in mind. What many of us don't realize is the interaction of corticosteroids with some of the other drugs that we commonly use in our seizure patients, in terms of anticonvulsants, in terms of anticoagulation, less commonly with antifungals, but also with our diabetic agents and some of our antibiotics, though we typically don't want our patients on macrolides because of the potential worsening that they can experience. Certain of our diuretics, such as furosemide, hydrochlorothiazide, are impacted in terms of their pharmacology with the use of glucocorticoids. And of course, vaccination. Now, in the MG patient who's on any IST should never receive a live vaccine, but they may if we are pre-treating them or if we're using them prior to the initiation of an immune suppressant drug. So a number of strategies have been developed in terms of dealing with these adverse events that are glucocorticoid related. Treat the pre-existing comorbid condition that has caused it. That's easier said than done in many instances, but we need to do a good faith attempt at it. While it's best to use the least effective dose, steroid dose to treat, and to use the minimum time period to treat, that's not overly clear in the myasthenic population. How much steroids do we need to get the patient under control? Ideally, we'd like to avoid the use of steroids. And I think with new targeted therapies, we're starting to achieve that capability. And I think it's fair game to say that if they have selected risks that may be worsened by corticosteroids, it's a reason not to use them and move to another alternative therapy. And Dr. Silvestri will speak about that. Some folks consider intermittent or alternate day dosing if possible. When I was trained, we started with high-dose daily prednisone, but the minute we saw improvement, they went to an alternate day program and then tapered thereafter. We need to really determine how fast can we taper. There are papers that say we can taper rapidly. There are other individuals who don't feel that that's appropriate, that it may increase the risk of a myasthenic exacerbation. So we still need further information there. And then we need to consider the use of nonsteroidal immune suppressant drugs. And here are some listed for vasculitis and asthma and rheumatoid arthritis, but we would use the same, many of the same therapeutics in treating myasthenia with mycophenolate, azathioprine, methotrexate, the calcineurin inhibitors, for instance. And so we tell our patients that you should carry a steroid treatment card. You should inform your healthcare provider that you see in consultation, etc., that you are on corticosteroids. We need to apprise them of the potential for mood alterations, and we should be prepared to enlist the aid of our psychologists and psychiatrists should this occur if they don't respond to simple therapy that will manage their mood change. They need to be aware that they need to stay away from individuals who are receiving live vaccines or who have significant viral illnesses for fear that they have an increased risk of catching them. And then they should adopt lifestyles. And as I said, this is easier said than done to modify those behaviors that will increase their risk. Healthy eating, smoking cessation, physical activity, etc. John Stone, who's an endocrinologist, has tried to develop a glucocorticoid toxicity index that measures the risk of steroids over time. And it's starting to gain interest and use, originally developed for therapeutic trials. And it's a standardized assessment. It was developed by an international group of some specialists, and it measures change in toxicity between 2 points in time. So it's a longitudinal assessment that gives valuable input here. And it's been validated, and a worse score means worse impact in terms of steroids. And this list, and we're not going to go into detail, looks at multiple domains and the methodology by which they're assessed. For instance, bone, we're looking at DEXA. Lipids, we're looking at LDL, glucose, A1C, etc. This has now been modified to an abbreviated version that may be useful in routine clinical practice, looking at BMI, glucose intolerance, blood pressure, and lipid metabolism. And the hope is that ultimately this will be incorporated into our clinic workflow. And patients can actually track their own scores and look at impacts. They need to be educated to do that, of course. And so I want to start here with a case. This is Sebastian, 56 years old, has type 2 diabetes, hypercholesterolemia, and he was treated with azathioprine and prednisone. So he initially began 1 milligram per kilogram of prednisone. This is how we used to do this, high dose daily. Hit him hard, control the disease, and taper. And following that, he was tapered off. He was now down to 40 milligrams alternate day. He was on azathioprine, 150 milligrams a day, somewhere between 2 milligrams and 3 milligrams per kilogram. But adverse events ensued. 30-pound weight increase, loss of diabetic control, and now he requires insulin. So, what do? Is the steroid dose appropriate? Should it even been started on that steroid dose? How do we address these side effects? How can we get this weight off? How do we get his diabetes under better control, get him back to where he was pre-steroids? Should we have had a better monitoring plan in place? Or, as in the case in this individual, some year and a half later, he pops up with glucose intolerance due to polyuria, etc., and it's diagnosed there. And would the GTI have been, if it were the standard of care, would have been used? And I would dare say the latter, yes, it would have been quite helpful to use. I think we should have been monitoring him longitudinally. We probably should not have even started corticosteroids, given that he has type 2 diabetes. Even though he was well controlled at the time, it would be likely that we would take him out of oral control. He would require insulin. I'd like to introduce to you Dr. Nicholas Silvestri, professor of neurology at the Jacobs School of Medicine and Biomedical Sciences in Buffalo, New York. He's going to speak to you, sparing the steroids with FcRn inhibitors, evidence from bench to bedside. Nick?
Thanks very much, Dr. Howard. I appreciate it. And without further ado, we'll get started. So let's just take a step back for a minute and review the myasthenia gravis pathophysiology. In the vast majority of our patients, as Dr. Howard mentioned, we're dealing with patients with acetylcholine receptor positive disease. So about 85% of our patients have acetylcholine receptor positive disease. In the case of acetylcholine receptor positive disease, the antibodies exert their action on three ways. One is by binding to the receptor and physically blocking it so that acetylcholine cannot attach to the receptor and therefore neuromuscular transmission can occur. Secondly, the antibodies can cross-link the receptors, and when they're cross-linked, they can be internalized and then degraded, so there are fewer acetylcholine receptor antibodies available for neuromuscular transmission. And then finally, the antibodies can activate complement, and when the antibodies activate complement, it can lead to the formation of the terminal complement complex, which physically destroys the neuromuscular junction through creating basically pores and lysing the neuromuscular junction. So let's talk a little bit about characteristics of select steroid-sparing therapies. Dr. Howard really stressed the importance of trying to think of a different plan for patients. We can't keep patients on steroids forever, and in some cases we shouldn't put people on steroids at all, as he mentioned. And so some of the steroid-sparing agents that have been used to treat myasthenia gravis over the years include azathioprine, which has its effect on B and T cells, much like mycophenolate, which we'll talk about in a second. You can see the dosing here in myasthenia gravis for azathioprine is about 2 to 3 milligrams per kilogram per day. But the major risks associated with azathioprine are bone marrow toxicity, hepatotoxicity, and GI toxicity. I'm going to go down to mycophenolate first before I come back to IVIG. Again, this works on B and T cells. Typical dose is anywhere between 1,000 or 1,500 milligrams twice a day in MG. And again, the most common side effects here are GI toxicity, a lot in the way of nausea and diarrhea, bone marrow suppression, and it's teratogenic, so it should not be given to women of childbearing age. And if we go back to IVIG, we're not quite sure, I think, what the mechanism of action of IVIG is, but it probably has a broad immunomodulatory effect. You can see the doses listed here. However, patients getting IVIG can experience hypersensitivity reactions, kidney problems, particularly in those that have pre-existing kidney disease, thromboembolic events, as well as infusion site reactions, which can include flu-like symptoms as well as headache. Let's take a minute and talk about thymectomy. So thymectomy has been done to treat myasthenia gravis for almost 100 years, but it wasn't until a few years ago, it wasn't until 2016 that Dr. Wolf and colleagues published the results of the MGTX trial, which was the first randomized trial of thymectomy in non-thymomatous myasthenia gravis. And these are patients, 126 of them worldwide, with the characteristics you see here, who are randomized 1-to-1 either to undergo transsternal thymectomy and treatment with prednisone versus prednisone alone. And what you can see in the graph below is that patients that underwent thymectomy had a better outcome in terms of not only clinical outcomes, which we're not showing here, but reduction in prednisone doses, which we see actually in the QMG scores here, the thymectomy plus prednisone group doing better over time versus those treated with prednisone alone. So this was some absolutely essential and helpful data to show once and for all that yes, in non-thymomatous myasthenia gravis, treatment with thymectomy is a good option. Again, just talking a little bit more about thymectomy, this is recommended by international consensus guidelines, last updated in 2020 and currently undergoing revision. So for patients aged 18 to 50, it should be considered in the case, again, of acetylcholine receptor positive non-thymomatous MG. And if patients, regardless of their age, fail to respond to other therapies, it should also be a treatment consideration. And here's just a throwback to your anatomy, reminding you of where the thymus gland lives in the anterior mediastinum. Let's talk a little bit about regulatory updates on newer therapeutics for MG. We can see here that there are a couple of medications here that are complement inhibitors. So the top 3 agents listed here, eculizumab, ravulizumab, and zilucoplan, have all been approved to treat generalized myasthenia gravis in patients with acetylcholine receptor positive disease, whereas eculizumab and ravulizumab are monoclonal antibodies. Zilucoplan is a macrocyclic peptide. The other differentiating feature here is that eculizumab and ravulizumab are intravenously administered, whereas zilucoplan is subcutaneously administered. And you can see the different dosing regimens here. These medications are generally safe. The most common side effects are listed. What differentiates really based on the route of administration eculizumab and ravulizumab from zilucoplan as the development of injection site reactions in people on zilucoplan, which can occur at a low incidence, again, predominantly due to the subcutaneous route of administration. When we go to the bottom two medications on this list, efgartigimod and rozanolixizumab, these are agents that are fetal neonatal receptor antagonists, or FcRn antagonists. Efgartigimod is an antibody fragment, whereas rozanolixizumab is a monoclonal antibody. And another differentiating feature is that rozanolixizumab has the added indication for MuSK antibody positive myasthenia gravis. Efgartigimod is available as an IV or subcutaneous form, whereas rozanolixizumab is a subcutaneous infusion. The dosing regimens are quite different from patient to patient. And you can see, again, these are relatively well-tolerated medications, the most common side effects being infection and headache. Let's talk about complement inhibitors a little bit. So as I mentioned in the very first slide I presented today, one of the major reasons for the pathophysiology of myasthenia when it comes to the more common acetylcholine receptor positive disease is that these antibodies attach to the acetylcholine receptor and they activate complement. And you can see here the MAC, the membrane attack complex, or what's also called the terminal complement complex now, actually leads to a destruction and oversimplification of the neuromuscular junction at the postsynaptic membrane, which again leads to impaired neuromuscular transmission and therefore symptoms in our patients. So not only do we have 3 complement inhibitors available now to treat patients with myasthenia gravis, there are a few products in the pipeline. There is a subcutaneous anti-C5 antibody that is available with phase 3 and recruiting. There's cemdisiran and pozelimab, which has 2 mechanisms of action. The first being an siRNA that suppresses hepatic C5 synthesis, and the other mechanism there is an anti-C5 antibody. This is also a subcutaneous injection, which is recruiting in phase 3. As well as a C1s inhibitor, another way to inhibit complement along the pathway. Again, subcutaneous formulation in phase 2 and currently recruiting. Shifting from the complement inhibitors and now talking about fetal neonatal receptor antagonists. So the fetal neonatal receptor has been known for a long time. What happens under normal circumstances, as you can see in this depiction here, is that when IgG antibodies are brought into the endothelial cell as a way of recycling and prolonging their half-life, those IgG antibodies that attach to the fetal neonatal receptor are then recycled back into circulation, again, thus extending their half-life. And those that are not attached to fetal neonatal receptors, are shunted into the lysozyme and destroyed. So if we can block the fetal neonatal receptor, what it ends up doing is shunting more of the antibodies, including pathogenic acetylcholine receptor antibodies, into the lysosome so they're degraded, therefore recycling lower levels of IgG, again, including pathogenic IgG, either the acetylcholine receptor antibody or the MuSK antibody back into circulation. So think of this as a way to essentially reduce antibody levels in the bloodstream, including pathogenic antibodies, as is in the case of myasthenia gravis. So blocking FcRn targets the antibodies that drive myasthenia. Again, I think I kind of went through a lot of these points on the previous slide, but this works really only through IgG. It spares the other immunoglobulins, A, E, M, and D, but it does, under natural circumstance, perpetuate the half-life of IgG antibodies. And this has been, we've known this for years, that removing these antibodies works because that's what we're doing with plasma exchange. However, FcRn IgG autoantibodies, they provide greater selectivity. It's a more targeted therapy than the more broad forms of therapy that I talked about acting on B and T cells a little while ago. So let's talk about efgartigimod alpha. This was the first FcRn approved. It was approved in 2021 in its IV formulation, and then in its sub-Q formulation in 2023. This is a first-in-class human antibody fragment that antagonizes FcRn and blocks the recycling process of IgG, which we just talked about. The IV dosing starts at 10 milligrams per kilogram body weight for 4 weeks. So it's a weekly infusion given for 4 weeks. And then subsequent infusions are really based on different prescribing patterns. So for me, I give cyclical dosing, 4 weeks on, 4 weeks off for 3 cycles. and then adjust the dosing regimen based on the patient's response to the medication. The subcutaneous formulation, very similar dosing, except the dose is actually not weight-based. It's a standard dose given weekly for 4 weeks with time off in between, and recycling the doses, as I talked about, similar for IV. And adverse events we kind of covered already in a previous slide, but those most commonly seen are infections, headache, and hypersensitivity reactions. The value of efgartigimod was shown in the pivotal phase 3 ADAPT trial. This enrolled patients with mild, moderate, or severe myasthenia gravis. It enrolled actually acetylcholine receptor, MuSK, and seronegative patients, but the primary analysis was really focused on the more common acetylcholine receptor positive subgroup. Patients were randomized to either receive efgartigimod or placebo, and again, they were also on their standard MG medications at stable doses leading into the trial. And what is seen here is we're looking at first antibody levels. And so you can see that compared with placebo, efgartigimod reduces IgG antibodies in patients receiving efgartigimod versus placebo. It did not change the other immunoglobulin levels like we talked about, nor did it have any effect on albumin. From a clinical standpoint, however, again, the antibody data is nice, but what we really want to know is what does it do to patients' clinical status? And you can see that the ADAPT trial met its primary outcome, which was the percentage of MG-ADL responders versus placebo, and the key secondary outcome was the percentage of QMG responders versus placebo. And what we see here is that 2/3 of patients, 67.7% of patients receiving efgartigimod versus only 30% of patients that received placebo were classified as MG-ADL responders, which is a change in the MG-ADL score of 2 points or more, indicating a clinical benefit. Similarly, in terms of QMG responders, that's defined as a QMG change of 3 or more. That was seen in 63.1% of patients receiving efgartigimod versus only 14% of patients receiving placebo. So it's also important to know that not only is the medication effective, but it works fairly quickly. So off to your left, you see that in 84.1% of those patients who were classified as responders, they actually had that effect within 2 weeks. So it's an effective medication, and it's one that works fairly quickly compared to the other medications that we're used to using in myasthenia gravis. This demonstrates the different dosing regimens that were seen in the clinical trial. You can see there's variability across the board in terms of when patients in the clinical trial needed to be redosed. I would say in clinical practice, working with efgartigimod now for almost 3 years, you do tend to see a bit of a variability of when patients do require redosing. And I think that this trial results actually breed true in my clinic experience as well. This demonstrates that prior to this, we showed the ADAPT data, which was initial dosing and what the effects were. What this looked at is over time, do patients have the stable or a sustained improvement that's repeatable from cycle after cycle? So these are repeated cycles of efgartigimod superimposed on each other in patients, and you can see that cycle after cycle, the effect was the same. So there does not appear to be a wearing off effect or a loss of effect response seen in patients treated with efgartigimod. And then, so switching from IV to sub-Q, this was a non-inferiority trial where patients were treated with either efgartigimod IV or sub-Q efgartigimod. This was a PD/PK study, and this demonstrated non-inferiority in terms of reduction in Ig levels, therefore leading to the approval of sub-Q efgartigimod. And you can see in this slide here that the effect on muscle group subdomains, so this is post-hoc analysis of ADAPT, and what you can see in this slide is that across the board, when you look at different domains of the MG-ADL, that patients treated with efgartigimod, depicted here in blue, had better responses compared to patients treated with placebo. What about quality of life? Dr. Howard actually started the presentation talking about the impact of myasthenia gravis and its treatments on patients' quality of life. You can see here in patients treated with efgartigimod versus placebo, they had improvements in their MG-QOL-15, which is a quality of life scale, which has been validated in myasthenia gravis. So in addition to other functional outcome measures, we definitely demonstrated an improvement in QOL as well. Shifting from efgartigimod to rozanolixizumab, this is another FcRn antagonist, as we talked about earlier, that was FDA approved in 2023, and it does have the additional indication for MuSK-positive patients in addition to acetylcholine receptor-positive patients. This is a monoclonal antibody, again, acting as an FcRn antagonist, and the dosing is weight-based, as you can see here, and it's given in a cyclical nature similar to efgartigimod. The most common adverse events reported in the trials of rozanolixizumab, particularly the Myasthenia trial, were infection, headache, aseptic meningitis, and hypersensitivity reactions. The Myasthenia trial that I just referenced was the pivotal phase 3 trial of rozanolixizumab. 200 patients with either acetylcholine receptor positive or MuSK positive myasthenia were randomized to receive rozanolixizumab versus placebo. And what we can see is that there was clinically meaningful improvements in both the QMG and the MG-ADL and other patient-reported outcome measures in patients treated with rozanolixizumab versus placebo. The reductions in MG-ADL to day 43 were higher in the treatment arms than in placebo, as you can see here. And the most common adverse events that were noted were headache, diarrhea, pyrexia, occurring comparably actually across the groups. Similar to antibody data that was seen with efgartigimod, very similar antibody reductions were seen, both total IgG and acetylcholine receptor antibodies in patients treated with rozanolixizumab at either of the two doses that were used in the clinical trial versus placebo. In post-hoc analysis of the Myasthenia and open-label extension studies of rozanolixizumab, many patients achieved what's called minimal symptom expression, which is defined as an MG-ADL score of 0 or 1. That's what we're shooting for. We don't want patients to have any symptoms or perhaps one mild symptom due to myasthenia gravis. And you can see that over the course of cycles, that almost a quarter of patients achieved this after cycle 1, cycle 2, and cycle 3. And this was further amplified with further cycles. In terms of the long-term safety data and the Myasthenia trial and the OLE, the infections we talked about earlier, it's important to know that headaches and GI side effects were the most frequent in cycle 1 than in subsequent cycles, whereas the incidence of other events were seen consistently across cycles. Most of these events were mild or moderate in intensity. 8 patients, or 4.3% of the study, experienced severe headaches and serious infections. And there was one case of serious aseptic meningitis, which led to withdrawal from the study. But there were no serious hypersensitivity or anaphylactic reactions, no potential liver or kidney toxicity, or meaningful changes in lipid or albumin levels with this product. Nipocalimab is another FcRn antagonist. The top-line phase 3 results were released earlier this year at EAN, and we had some further data released here in the AANEM MGFA meeting a few days ago. This, again, is a fully humanized monoclonal antibody that works to block FcRn. Very similar study design as the previous two trials. And the top-line data demonstrated the mean MG-ADL score has decreased by 4.7 points from baseline in the nipocalimab arm versus 3.25 points in the placebo arm. Similarly, the QMG point decreased by 4.86 in the nipocalimab arm and only 2.5 in the placebo arm. And the adverse events were comparable across the treatment and placebo groups. What's on the horizon? Well, there's another FcRn antagonist, which has completed their phase 3 trial. That's batoclimab. And we anticipate study results early next year. And what about self-injection? So right now, efgartigimod, as I mentioned, is available as an intravenous or a healthcare provider administered sub-Q product. Efgartigimod, a pre-filled syringe, has been filed with the FDA, and hopefully we'll get answers on that soon. Similarly, rozanolixizumab has looked at self-injection as well. And then there's another trial looking at continuous versus cyclical dosing of efgartigimod. So let's revisit Sebastian's case. That, again, was the case that Dr. Howard started with in his portion of the presentation. As a reminder, Sebastian is 56, and he's a man living with GMG. He's got type 2 diabetes and hypercholesterolemia, and up to this point, he's been treated with azathioprine and prednisone, and experienced a lot of side effects, as Dr. Howard mentioned. And so really, after thinking about the newer agents available, the complement inhibitors and the FcRn antagonists, would it be reasonable to transition this patient onto an FcRn antagonist? And is there a case to be made from avoiding steroids at the outset in this patient? So Dr. Howard touched on that. Perhaps seeing this man has diabetes and hyperlipidemia, would it be wise to avoid steroids altogether and perhaps use a fast-acting effective agent like efgartigimod or some of the other agents that we talked about? And then what are the safety and dosing considerations to note in sub-Q or IV use of efgartigimod and other FcRn antagonists? So I think that as I pointed out in my presentation and as I mentioned in my clinical practice, the dosing can be variable from patient to patient, but most patients are able to find a particular dosing regimen that's sufficient to control their MG symptoms. Dr. Howard, I will now turn it back to you.
Thanks, Nick. So we spoke about the potential strategic use of FcRn inhibitors and tailoring it to specific solutions in GMG management. When we consider using FcRn inhibitors as an alternative or adjunctive therapy to long-term corticosteroids, the goal is to reduce or eliminate reliance on steroids. While highly effective in many patients, their adverse event profile for some is just not acceptable at all. So we need to select the appropriate treatment options based on disease severity, their comorbidities, as we've discussed, in particular the MG subtypes. There are some that are applicable only to AChR, others to AChR or myasthenia, and other individual factors. It's a shared decision-making process. And then the challenges and considerations in transitioning or combining therapies have to be taken into account while we aim for our steroid-sparing goals. And so we want to think about the practical strategies for the initial assessment and monitoring for treatment response and the adverse events that may potentially occur. We want to determine whether or when to administer subsequent rounds of therapy, as Nick alluded to. We've already talked about it's a shared decision-making process that's individualized to the particular patient and their particular needs. And the overall goal, in addition to efficacy, is the reduction of potential adverse events such as infection. FcRn inhibitors may carry a risk for increased infection. My personal belief is that it is nominal and not that much more than the general population, but in selected patients, it may be of concern, so we need to keep that in mind. We also have to think about vaccination scheduling. If we're sucking out all of their IgG, are we able to mount a proper vaccine response? This has been studied. Yes, one can, though the level of vaccine immunoglobulin is not as high as it would be. And so proper sequencing, if you will, usually about 2 weeks after receiving FcRn would be appropriate. And then we need to think about pregnancy and remember that the FcRn is the critical means by which maternal immunoglobulin is transferred to the fetus in the last trimester of pregnancy. And so it should not be used in that setting, though people are using it in the first 2 trimesters of pregnancy. So in summary, corticosteroids, while a long mainstay of our therapeutic armamentarium in MG, is broadly immunosuppressive. It's not effective in some patients, but it's associated with a plethora of adverse events that we would like to get rid of. And so advancing our understanding of the pathogenesis of MG has led to novel strategies, such as FcRn inhibitors, complement inhibitors, which reduce levels of autoreactive IgG antibodies, with the former offering effective, safe, and well-tolerated alternatives to the extended use of prednisone and prednisolone, etc. There are 2 that are currently available to treat GMG, efgartigimod and rozanoliximab, as Nick has talked to you about. And these antagonists have the potential to reduce burdens associated with steroid-based treatment. And with that, we're going to move to the question and answer period. And thank you for submitting all of your questions into the chat. We have many more than we can answer, but let's take a few here for you. Nick, should existing patients on any steroids be weaned and switched to newer steroid-sparing treatments, regardless of whether or not toxicity has been reached?
I actually think so, Chip. I mean, I think that as I've said in multiple venues, steroids, it's not a question of if, it's when and how and what they're going to cause. So, absolutely, I think if a patient is still dependent on corticosteroids this day and age for myasthenia gravis, they should be transitioned to something. And I think the best something is probably one of these newer agents because they're more targeted, and as we talked about, have fewer short and long-term side effects. So, absolutely.
Thanks. One of the other questions is, can a patient taking anti-C5 medications go completely off steroids? Yes, we've been able to achieve that in some of our patients. During the trials, which are fairly artificial, we were not allowed to adjust concomitant medications in the open label. But in the clinical practice registry data that we're collecting, patients are being completely weaned off. Another question for you, Nick, is uh, which steroid-related toxicity should be particularly vigilant for during early periods of treatment?
Oh boy, I mean that's a great question, but a tough one to answer because I would
Yeah.
argue all of them. I think the one I'm most worried about, particularly in my older patients with a lot of medical comorbidities and the metabolic syndrome and the like, is really diabetes and dysglycemia. And I think I'm saying that because I've seen people frankly have to go to the hospital with hyperglycemia and have to be treated aggressively for that in the midst of steroid therapy. But I don't know that I can just pick one.
Yeah, I don't think you can either. I think the one that's most easily monitored is weight gain.
Right.
And the individual who starts, you see 2, 3, 4 kilogram increments every time you see them is one that I may be a tip off that they're going to be getting into further trouble. Um, Another question we have is, can you provide examples of when we might consider recommending IV versus sub-Q FcRn therapy, assuming that most patients are opting for sub-Q? I think it's a shared decision-making process. I will tell you that I have a cardiothoracic ICU nurse who refuses to give herself an injection, even though she's administering needles all the time, and prefers the IV. Another example I've seen is the older population, widowed, widows, etc. They see the IV infusion as a social event where they catch up with their friends and can have a conversation during the period of time of infusion and post-infusion monitoring. But it's really patient choice that dictates which one will be used in my experience. What do you think, Nick?
No, I think you hit the nail on the head, Chip. I mean, it's really patient decision, and I'm a firm believer in the data and that the FcRn therapies are equivalent when it comes to efficacy. So I really lay out all the options to patients when we come to the FcRn level of therapy, and really work with them to understand what the various options are, both from a dosing standpoint as well as a route of administration standpoint. And as you pointed out, people make decisions for all sorts of reasons, some of which I understand and some of which I'm left scratching my head. But at the end of the day, it's the patient that's receiving the therapy, not me.
Yeah. Another great one here is, what's the potential of steroids to exacerbate pre-existing osteoporosis in older women? Would you avoid steroids completely in this population?
Yeah, I mean, I think that's another great example of where we really need to think twice. I think practically speaking, you might have to use steroid in the acute phase. For example, I can write a prescription for prednisone and I can know that the patient can get on it, that day from their pharmacy. Whereas with some of the newer therapies, as you can imagine, there can be a little bit of a delay. Thankfully not a very long delay, but with authorization and administration, sometimes a week or two counts. So you might use a lower dose of steroid to stabilize in the short term until you can be assured that newer medication or the other medication is going to be administered, and then wean the prednisone away. But in an ideal world, it would be great to avoid prednisone in everyone. But yeah, when people have pre-existing medical problems that steroids are known to exacerbate, such as osteoporosis, diabetes, glaucoma, et cetera, it would be fantastic to be able to avoid these altogether.
I would agree completely. One of the questions we've received, again, thank you all for submitting them, is, are you using GTI in your practice, and do you think it can be applied in the real world setting across the board? We are beginning to use the modified version of the GTI in practice, and we're doing it more in a clinical research mode. And I know Neelam Goya at Stanford is running a study with it. But I do think it has applicability in our clinical practice day to day. It's a fairly straightforward algorithm. The longer version of the form, which is not as readily available, has been validated to show interval toxicity. And I think it has applicability. I think part of the problem is that we don't think about the adverse events of steroids in our busy practice. What's the impact on skin? Are we seeing skin thinning? Are we seeing bruising, breaks in skin for a risk of infection, etc.? I think we all, or many of us, routinely screen for diabetes and osteoporosis, but these other things, do we screen a non-neuropathic patient for sensory loss using monofilament fibers, etc., or good detailed sensory exams? Often folks are too busy to do the latter, but these simple things I think we can begin incorporating in this modified version may be quite helpful and will be applicable in day-to-day. Nick, what do you suggest for preventing or managing infections with FcRn agents in GMG?
Yeah, I mean, I think that it's a question of, recognizing, as with all of the other medications that we use, that, we're manipulating the immune system, and that when we do that, we do, for the vast majority of the agents we use to treat MG as well as other autoimmune diseases, put people in a higher risk for infection. So that's true of FcRn antagonists, and really it's just kind of common sense, making sure you stay away from sick people, maybe avoiding crowds in times of increased infection risk. Washing your hands, that sort of thing. But, I don't think there's really any need at all for, prophylactic antibiotics or anything, if that's where that question was directed. It's just a question of really preventative care.
Yeah. Well, here are two questions that I think I can combine. And the first is there any GMG patient now that you would start on a steroid-sparing treatment from the outset? And the follow-up is, or not follow-up, but the second one was, what baseline comorbid illnesses would make you cautious about starting a patient with GMG steroids? And so I try to avoid steroids in my older populations, anyone who has diabetes, anyone who is modestly or morbidly obese, any of my elderly individuals who have a hint of osteopenia, osteoporosis. I will not use a corticosteroid in them. I will move directly to a non-steroidal immune suppressant. My choice over the last couple of decades has been mycophenolate mofetil because it works faster than azathioprine. Because it works or takes so long that I use a bridge therapy. And in the past, we have used therapeutic apheresis on a periodic basis to achieve this. Now I would consider using an FcRn inhibitor to bridge the gap while we wait for these others to work. Well, I want to thank all of you. We've run out of time. I know we didn't get to all of your questions, but do thank you. I want to thank Nick for his participation in this. And again, thank you very much and have a great day.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from argenx US Incorporated. To access all materials for this activity, visit peerview.com/JDS860.